Okay, welcome back. It's been a while. Good to see all. Please continue to eat. I want to welcome our great guests on the dais today. Sitting to my left is Dipanita Das, CEO and co-founder of Sociero. Is that right? As well, Dr. John Halamka, president of the Mayo Clinic platform at the Mayo Clinic. Vidya Raman, chief medical officer at Teladoc Health. And good afternoon to all three of you. I'd like you to, if you can, answer one question to start is, why are you here as we are here gathering for Bot or Not? Vidya?
Thank you. Thanks, first of all, for having me on the panel. It's great to be here. Why am I here? Well, so my career over the last 20 to 25 years has been at the intersection of clinical science, data technology, and the ecosystem. And personally, I'm very, very passionate and a big believer in the power of insights from data to transform lives, to change lives, to save lives. And I just cannot wait to be a part of it. So I'm continuing on my journey.
So if we think of the last remarks of what are the challenges in American healthcare, there's only one way to solve them, and that's working together. So I always enjoy coming to Milken because we have such an extraordinary degree of collaboration and partnership here. And we'll curate the world's data, we'll create fair AI, and we'll get it used.
My career has been using data and emerging technology to move the needle on some of the most important issues of our time. There's climate, there's education, criminal justice reform, and now healthcare and life sciences. And it's an absolute privilege to be able to use one of our most defining technologies to impact healthcare for the better.
Vidya, you heard the conversation where we were talking with the director earlier, just before you joined us on the dais here. What is your reflection on what was said? And really, if I were to generalize and summarize what we were talking about, what's working, what's not? Mm-hmm. And for you, thinking of our very topic of bot or not, what is working?
So let's maybe I've been in numerous conversations over the last 2 days, all to do with this topic. But let's look at the backdrop. Where are we today, right? Unprecedented time, where we are looking at rapid discovery and availability of multimodal data, genome, transcriptome, proteome, metabolome, other clinical data, consumer-generated data, claims data, context data, happening at the same time as rapid advances in computing technology, connectivity technology, technology around data security and privacy. The confluence of just those two alone has brought us to this threshold of transformative phase in healthcare. So I would say it is that confluence alone is working, and what we're able to really leverage is the power of AI, like the director was saying, to look at large data sets, multimodal, multifaceted data, and to glean patterns, relationships, possibly inferences, right? So what AI is really doing is making sense of new science, new data, and transforming or translating it into knowledge. But it will take a human to apply that knowledge into care experience, care pathways, and care protocols, and a human-centered way of designing those pathways and protocols. So, and it really entails that, physicians, others in healthcare shouldn't be viewed as passive recipients of an AI platform. Instead, they should be viewed as co-creators and partners of those solutions. And we, those of us on the clinical side and the healthcare side, should cross-skill, upskill ourselves to become more familiar with digital data and AI so that we can really proactively and in a more meaningful way participate in the next era of healthcare. So there's a lot, I would argue, is working.
Dr. John, you said that it used to be data sets and data storage as a limiting factor, right, a constraint. That's no longer a constraint. So what is the constraint that you now see in your conversations around this space, if that no longer is as big of a constraint as it was before?
Well, I think to your point, so technology, and I've been at this for 40 years, was limited. Storage, compute, access to expertise and tools, not a problem. Policy was a challenge. What could we do? What are the safeguards? What are the guardrails? We've come together to figure that out. So what's left? Psychology, culture, resistance to change. And in so many of the forums that we've had,
You're a data guy, right?
Yeah, yes. Well, but I'm a physician too, right? So, but point to be made is I've been in 21 countries this year.
Yeah.
And what you see, and at the dinner at Milken with the EU ambassador, the discussion was, who is going to move first? Who is going to accept risk? Who is going to manage innovation for what it is, which is potential huge benefits, but you have to accept along the way some things will work and some things will not. So to me, it's behavioral change in psychology that is the rate limiting step today.
So none of the other issues that we think related to technology specifically in terms of the constraint. It's very interesting. So nothing you're saying on the back end, if you will, is constraining us.
Well, how about this? Those are all solvable problems.
Right.
I mean, we all know that data in healthcare isn't great.
No.
But you can curate it and you can manage it. And there are issues of privacy and security, and those are addressable. So how about this? 2024 began with many feeling reluctance about adopting AI. 2024 is ending with people saying, we must move forward.
Mm-hmm. And how?
Well, and then what are the steps to curate the world's data, to validate those algorithms as being good enough, and to start putting them into workflow so we gain the benefit?
Dipanita, since we're talking about data sets, patient data and standardizing that, you have mentioned that that is one of the challenges in the space still. Again, 2024, when we knew back in the 1990s and the 2000s, okay, we can now apply this now that we have the security available to us on the back end. Why is this still an issue?
Well, there are a couple of things. One is, the thing that John pointed out around behavior change, that isn't just about adopting new technology, but actually changing behaviors around data as well. AI is only as good or bad as the data that's fed into it. And the worse and the dirtier the data, the more disparate, the less interoperable, the harder it is to build reliable systems that can repeatably and scalably do a thing that will actually help. So we believe in the human plus AI loop is actually really important. But in order for us to do AI well, we're going to actually have to fix how we collect data, whether it is making sure it's collected more diversely, more systematically, or just in the same way. Because if 10 different EHRs are formatted in different ways and have slightly different information, you're just going to make a lot of errors when you're trying to find a pattern. And that's true for absolutely everything. And in life sciences as well, as we find that companies are measuring different things about their customers, about their reach, about their success. So unless we have standardization, both in the data collection as well as the measurement, I don't see AI alone being able to transform healthcare. And a good part of it goes back to behavior change.
I want to build on that. And again, let's look at one part of the video, and that is the very idea that do we have the right data? Do we have enough primary data? Is most of the data we have late stage in these disease paths? Is it secondary and tertiary? Is it observational as opposed to primary data? All these questions, again, me just being a journalist and not the expert here, when it comes to data sets.
So it's a combination of multiple things, but I think what now we are seeing is the need to embed insights from real-world evidence into care, which is new. Right? You didn't take in as much real-world evidence. So let's, talking of large data sets. So think about, I'll give you an example. Risk stratification. Those of us in healthcare, right? We know that, to take an example, high BMI correlates with high cardiometabolic risk. But some studies have shown that when you let some AI models do some unsupervised learning, they actually cluster patients with obesity into 5 different clusters where you don't necessarily see that correlation. You could have a high BMI and low cardiometabolic risk and vice versa. Why is that important? Because now you get to care, you get to treat differently. So the question really in front of us is, should we be reimagining care? Let's look at conditions, the top 20 conditions by cost, by prevalence, by severity. Look at how we provided care to date. What's working, what's not working? Are we hitting outcomes? Is there coordination? What are the gaps? And with all of these new assets and new insights, should we really be providing care the same way? I mean, I would offer that it's time to reimagine, sit down, and think about all of those problems that can be solved. You look at wellness data, it was in a couple of other sessions too, lifestyle data. We're all wearing some sensor or the other, wearables and device and sensors. So much data in, on, around the body that's being collected. Where is it going? Do you get any insights? If I walk 5 miles, I know I've done 10,000 steps. I don't need my watch to tell me that, right? But what I do want my watch to tell me is when I walk my 5 miles or run my 5 miles and I sleep well, that I eat better the next day. So how do you take lifestyle data and kind of juxtapose one with the other? And we're talking large volumes that are being generated on a daily basis. So my point is, we don't need new data. We have a lot of data, but it's time to put it to very different use. Yesterday, there was a lot of conversation about prevention on a panel, right? How do you do that? Take the lifestyle and wellness data, start empowering me with those insights that I can use to change my behavior on a daily basis. This is something you can do with a Medicaid member as well as you can do with a commercial member. So we have to think about utilizing data differently. The concepts like patient engagement, I mean, this is something we struggle with all the time. We can't engage patients. Yeah, we can't, because there's no new value we're providing to them. So we did a quick experiment at Teladoc around patients with type 2 diabetes. So you use traditional predictive analytics to understand who's treading down the wrong path. In the past, you would intervene, but you would intervene in a one-size-fits-all manner. Now, we're taking that and juxtaposing generative AI and saying, okay, so I know who Richard is. I know I need to intervene. I know when I need to intervene, but let me now also use generative AI to say, what do I need to say to Richard, and how do I say it to him, right? So we have the data, but it's about putting it to different use, because now you have technologies that can help you do things very differently. Even, concepts like, all of us are here from some healthcare system. We have high-tech assets, high-touch assets. And I don't know about you, but in healthcare, I think we not only do one-size-fits-all, but we think everybody should buy every solution. No, not necessary, right? So how do you know if coaching might be right for me, may not be right for John, right? But over time, how do I know why coaching worked for me, for how long, what did it do for me, and kind of build on that. So yeah, so a lot of data, put it differently.
I mean, to the panel, so you're saying we have enough data, but do we have the right enough data?
Well, a couple of comments there. We all worry as we deploy AI that it is not going to be fair, appropriate, valid, effective, and safe. And just because I develop an extraordinary algorithm in Minnesota doesn't mean that it's going to work in Washington. In fact, if we develop an algorithm in Washington, D.C., it might not work in Alexandria, Virginia. And so, as you describe it, our data has to have 3 characteristics. Multimodal, as you said, different kinds of data, breadth, lots of patients, but heterogeneity. The old, the young, the male, the female, the white, the not white, the rural, the urban, the educated, and the not. And the challenge is, look at our clinical trial data. It is largely urban professionals, and we don't have a lot of rural patients. So we are approaching individual data sets that are birth to death in some locations, but it's not heterogeneous enough.
So this is probably one of my favorite topics. Don't let me go on too long.
Oh, you're in the right place then. You're in the right place.
My co-founder likes to say that he used to, in his previous company, crunch over 1,700 data points on 327 million Americans to sell them solar panels. And then we took his mother to a cancer center because she was diagnosed with metastatic breast cancer. And when you look at the way her treatment was being personalized. The word we're all reaching for is personalization, which isn't about volume of data, it's about depth of data. It's about capturing more attributes to identify a patient so you know precisely how to reach them or predict what they might, experience. It's about a pharma company, for example, knowing more about the physicians that treat those illnesses so they can target and support them with their better diagnosis or better use of their drugs. So really what I find here missing is depth. The number of attributes we consider before we make a decision on whether someone should or should not have a treatment or is likely to have this disease or not is just too light. So there's a lot of volume, but it's just not, you can't have that level of granularity and targeting. And that's really what AI is very good at, is the granularity and identifying you separately from me in the same context.
And asking the right questions, identifying the gaps.
Yeah, to build on that, so the cancer example that she used, right? Science now shows that conditions like cancer and obesity are not one condition, they're a confluence of tens, hundreds of conditions. That's how you should be thinking about it. So think about how complicated treatment can actually become, right? And how nuanced. But what we're actually seeing is the discovery of drugs in an expedited manner for the same conditions. Wonder why? Because we're able to compute the data and say, okay, oh wow, it's so nuanced, but maybe I can make it more targeted. Why does person A respond well, but person B doesn't? There's a study right now underway where, which is looking into why obese premenopausal women have better response to cancer treatments, but obese postmenopausal women don't. So it's the same obesity, but causing the two very different effects. So now they're studying the biology of the fat cells to take that data and transform it.
So are you saying, in a way, and I was sort of intimating this earlier as I transferred to you on this topic, does AI help us ask the right questions, better questions, than perhaps we might ask otherwise? And it sounds like you just identified as a kind of yes.
Yes.
John, by the way, please don't wait for me to ask all you. Please
No, just jump in.
Yeah.
But
Well,
yeah.
so let me just amplify what you've both said. And so my wife was diagnosed with stage 3A breast cancer in December of 2011. Think back 2011. The data we had was not very rich. I mean, it was some EHR data. So we went to a very prominent cancer center on the East Coast, and they said, well, we've got your data about you and your cancer, and we have a protocol for you. Well, how personalized is that? It's for women. Okay. Now, my wife is Korean, painter, was 50 at the time. Well, do you have any protocols for Asian women that have to have use of their hands because delicate movements with a brush are really important? You're like, we have no idea. So we actually, back then, I was CIO of Harvard Net's hospitals, were able to take the data of thousands of Asian women patients and figure out that the dose of Taxol we should use was half of the protocol. And she was cured with no neuropathy and is doing fine today.
Thank God.
So, I mean, to build on that, does the data set truly represent the population that you're trying to treat? And if you look at the grave disparities in data collection, we talk about clinical trials taking place in countries that do not fully represent the population that's going to have that disease burden. We go right back to the fact that we're keeping it very light. And if we don't intentionally go and seek out data for previously underrepresented populations or people or other attributes, we're only going to have some very, very surface solutions. Maybe one patient, maybe two, but it won't turn into a system. And at the end of the day, it needs to be a system.
One of the things that come to my mind, what's the analogy of what all three of you would like to see in this space of the application of AI in healthcare? And I was just thinking of a couple of things. I was a fintech founder 25 years ago. My idea was, well, if we can handle private patient data at this level, and we can do it in payments, and we've seen payments just take off comparatively in terms of the application of these very conversations. That's potentially one analogy to maybe where we could see AI being applied in the healthcare industry. Second is the Davos Alzheimer's Collaborative, which is going out and saying we want to look at 1 million people living with Alzheimer's across the world so that we can dive deep and we can go wide as well. A couple of analogies. Are there analogies that the three of you are watching that you would say, I would hope that we could apply some of the best practices from that here?
So I've been working on this for 40 years. And so 40 years ago, we didn't have EHRs, we didn't have cloud computing, we didn't have data standards. So what do we have today?
Well, what have you been doing? It's been 40 years. Come on, John.
I know. Well, we have data standards, we have cloud computing, we have the technical problem solving.
I got you. Thank you, man.
But what needs to happen is a global federated network of data coming together for the benefit of all. And we're starting to see this happen. If COVID taught us anything, it's that we have to reduce the competitive angst. And we can still have cooperation. I mean, that's fine. But I think to your point about Davos, we're going to probably see in 2025 the theme of Davos, which will be AI, emphasizing the need for country-scale cooperation on data while protecting privacy, but allowing bidirectional reciprocity for creation and validation of AI.
Anybody else?
Could not agree more. In fact, one of the things we've been trying to work on, my apologies.
No, go for it. Go for it.
To work on is to actually liaise with nonprofits on the ground organizations that are actually collecting procedure data or working with patients on the ground. Often the data doesn't make it through. Often they don't even have a real pathway to figure out where that data would be most useful or who might want to pay for it because it's so valuable. Is to start to partner with these organizations and help them figure out business models, what are they collecting, how to standardize it. And I think that is going to be transformational in terms of systematizing and standardizing what data we're collecting on population health.
Is there an analogy you're watching, Divya?
Analogy, I don't know, my mind goes to music, and
Yeah, please.
I sing, and there are many AI tools out there that basically, so it's interesting. So I first started to learn Carnatic music, which is South Indian classical music, when I was 10 to 12. Absolutely hated it when my teacher pointed out mistakes and said, nope, you're not doing it right. Nope, you're not doing it. I took it so personally. I let it go by the wayside. But as I got older, I realized that the only thing between me and pursuing that music is me.
Yeah.
So I decided to go back, right? Now I actually enjoy being told that is wrong because I love to decode it. So, okay, why is it wrong? And then figure it out, right? Yeah. And then put it back together and get it right. So the analogy to me would be, we've had the data in healthcare. We've used it in certain ways, some right, some wrong, probably not as well as we could. Now we have other types of data that we can take in, and all of these new technologies like AI that we're talking about, can we put it to different use, get it right? Let's decode what was done wrong, but create those new codes, right? And so there are some very simple, low-risk use cases in my mind. Look at health disparities, right? It isn't that cut or dry. It's never about race or gender or ethnicity or socioeconomic status. It's very nuanced, it's multifactorial. Permutations and combinations you wouldn't even expect. How are you going to solve for it? So let's put all of the data together, let the machine do its intelligence, tell us how to address the problem. That's a simple use case. Look at devices. Those are turbocharged today with AI, right? I think the last I read, there were 700 or so devices FDA approved with AI embedded, 3/4 of them in radiology, some in ophthalmology, some in cardiology. And if you're wondering, well, so what, right? Look at the possibilities of diagnosing, screening, preventing, treating faster, earlier, possibly cheaper.
Yeah.
Caregiving, I know a topic very close to your heart. I'm a caregiver. We took care of my mother-in-law a couple of years ago, completely in the dark. Yeah. But now you're talking of these devices with intelligence that can make us that much more smarter and provide care in a connected manner. So you're not feeling like you're disconnected from the clinical care team or your family members. And so there are some simple use cases. Geographic remoteness is another. So my point is that we have plenty.
Yes.
Let's put it to different use.
John, give me 2 seconds. Is that I was thinking, when I'm asking for analogies, I'm really asking for harmonics, aren't I? To go to what you're talking about. And since you said you're a singer, is there any of the songs that you decoded that you can share a little bit with us that's relevant to our topic today?
I was not told that I had to sing on
I know. I was just, anytime anybody is on air with me and they say they are somewhat, give me a note or
well,
give me a...
I don't know if Alo is here, but we had a great conversation on the shuttle day before yesterday. But no, listen, the form of music that I learn it's not just an art. There is a lot of science to it. There were most of the songs were composed. Most of the songs were composed like thousands of years ago, and there's math to it because you sing to a beat. Yeah. And it's a beat of 3, beat of 4, beat of 8, and so your mind is constantly processing way too many things, and as you know, virtual, right? Yeah. So I take my music lessons virtually, and when my guru says, you're not hitting the note, I feel like I am hitting it. But when I go back and look at my recording, I catch my mistake, right? And so my point is,
I gotcha.
So, and then there are AI based apps, which basically where I sing a note and I can tell whether I'm there or not.
So next time we're together.
Let's do it.
Okay.
Or maybe backstage.
John, who has perfect pitch?
Well, perfect pitch. Of course, figuring out what perfect pitch means and ground truth is hard, but let me give you some examples. My father-in-law died 13 years ago of stage 4 pancreatic cancer. Why is pancreatic cancer discovered at stage 4? It's just devilishly hard to visualize. It's often too late. Mayo, over the last several years, has taken every single case of pancreatic cancer and done a retrospective analysis of the images, and now with an algorithm can diagnose pancreatic cancer at stage 0. And it's curable. Right? So that should be our goal. Or similarly, I mean, you all are too young to have endoscopy, but let's say I've had it a couple of times.
This is a little personal, but I'll take it. Yeah.
You took us there.
Yeah, but it turns out even the best endoscopist will miss 15% of your small polyps on colonoscopy. AI reading the endoscopy can be 5 times better than a human. So it's to say the human is really important, but the AI makes the human even better, gives them perfect or near perfect pitch.
Can I share one more personal example since we're going to personal anyway? I went in for my mammogram 2 months ago, about a month and a half ago, and asked to see the radiologist. It's all normal, but I asked to see the radiologist because I can't wait till the next day to be called and told something. So he showed me the images, and he brings up my images on the screen. Lots of stuff circled in yellow. And it scared the heebie-jeebies out of me. And I'm like, what?
That's why they don't let you talk with a radiologist.
Right. But you see, it's like it's either that or you go home and then you're you're on an edge, right?
Yes, that's right.
So I said, so what is this? Well, he says, well, those are your right axillary lymph nodes. But don't worry about it. What the AI didn't do was compare it with my previous images. So today, that particular day, but the beauty is it pointed him to that, right? Yes. And said, okay, pay attention to this. That's collaborative intelligence. That's invisible intelligence.
So in the spirit of personal stories, although you are now convincing me to go back to music, I had 13 years of training that I also abandoned, and I hate my guru telling me that I was wrong. They're very tough on you. So PMS. Oh my God. Very annoying.
Why was there a pause after you said that?
Because I was waiting for some other folks
Someone
in the room to go, oh my God.
Like, aha, or ooh, or...
So it's a thing. It's not that, the menstruating person just loses their plot for a little bit. It's a thing. So I was talking to my therapist about this, and I was like, I am very concerned that these fluctuations are a bit too much, and it's kind of distracting me from work, and it's just kind of making me all loopy for a week, maybe 2 weeks a month, which is unsustainable because I have work to do. So she went and she did some research, and then we ran it through our engine and discovered that not only is this not a pattern, but...
Was the engine like, what it was...
So you know what it found? For all of those women, or all of those menstruating people, their estradiol would crash way below they're supposed to be. So during that period, all you need is really a pill that almost anyone can prescribe to you, and it isn't particularly expensive. And it changes like that. But the fact that when you run that blood test, and when my blood panel was done, my GP saw that number, but because they weren't really looking for that particular thing, they didn't consider that anomaly. But a machine can indeed just note that there is an anomaly, because to the point that John and that they have been making, you don't know that it is unrelated to what you're trying to diagnose. And I think that is really important. This is a simple example, but it's a very common problem, and it's one worth solving for.
What table was that, by the way? That's the reaction you were looking for. We had this conversation a little bit earlier on this topic, and one of the things when we get back to bot or not and our thematic for this conversation is AI and what I always like to say, AI and apples, or AI and water bottles. It seems like we've seen it all in the last 2 years. If we can couple AI with a topic, it reminds me of .com back in 2000. We'll put it on. And one of the comparisons I made is in journalism, we get a lot of broadcast folks that they want to become broadcast journalists, and we always will ask the first question, why? And if we hear, because I want to be on TV, we know you don't want to be a broadcast journalist, because it is because I want to be a journalist. What's the equivalent in this space? So we can cut through the AI plus blah.
Right, so if I get another pitch deck on the first slide that says, we are a generative AI and blockchain company, it is your equivalent of that. And so the question is, all of us want to not buy AI for AI's sake, right? We want to solve some sort of societal or business problem. So I meet with CEOs across the world, and what they say is the following. I am having a hard time with my margins. Healthcare is increasingly expensive. I'm having a hard time recruiting and retaining specialists, and we're not graduating enough of them. And everyone's burned out.
Yeah.
And if you have a solution to those three business problems, I want it. So that's what you need to do, is not AI water bottles, solutions to day-to-day business problems.
So I don't know about in journalism, Richard, but in healthcare, we do tend to John's point, we tend to think, preach, and sell features and functionalities, including AI. So even saying, oh, we do coaching, we do this, and we have LLM, we have AI. No, it's about the unmet need. What is the problem you're solving? Whether it's PMS, whether it's cancer, whether it's obesity, right? And there are so many unmet needs that we can point AI to that can take us, like, move the needle by leaps and bounds. Like things simply like people living in remote areas who have zero access to care. Like, and we're looking at like an 18 million shortage in healthcare professionals by 2030. So you put all that in context. There are just so many easier things to go after, low risk to no risk, things that can help us learn a lot. But to John's point, we just have to come together. We've got to break down the silos, think together, create the solutions.
What's your litmus test, to cut through that AI water bottles? What is it? How do you think about it? Is it the business problem? Is it patient outcomes?
It's for me personally, I mean, I lean towards health outcomes. I lean towards everything leading up to health outcomes. So outcomes don't happen by magic, right? You have to have the right solution. You've got to get somebody in the door so I can start applying AI there, how to bring you in, how to keep you engaged, how to know what's working, what's not working, and how do I personalize at scale? Like back 10, 15 years ago, the minute you use the term, personalization, people would say, oh my God, that's like, we're going to die because we can't be personalizing for everybody. But what AI will allow you to do is personalize at scale. And so, for me, if I can do that personalization targeting by leveraging AI, making the care teams, the clinicians smarter, and then drive towards health outcomes, fantastic.
Deepanita.
So customer discovery, it's an art and a science.
Yeah.
I probably interviewed 300-400 people before I even started the company. And if I literally interpreted what they said they wanted or what their pain point was, everything boils down to search. It's I can't find. And it took asking why are you trying to find, and what are you trying to do, and how are you going to measure something if you found it fast? Does it matter if you find it fast? Does speed even matter? Because sometimes it doesn't. You really, really need to be hyper-focused on the why, and then find near-term, medium-term, and long-term metrics to measure if applying AI or not, because applying AI isn't really the thing. It's solving the problem that you have to be obsessed with. But the hardest part with this is maybe near-term, all you're going to get is speed and scale, right? It's an efficiency game. That's all you will get. It might take you a year or two to see your customers be able to impact their key stakeholders. So it's actually also designing a very well thought out, iterative system of measurement to both check off on whether AI was the right thing to do, and even if it's AI, what kind, where, to what end. There's just a lot of discovery to be done. But my litmus test is very simple, is how is this going to change your work? And then how is it going to change the world of those you are working for?
And let me define what success might look like. So imagine that, and I'm not speaking to any one institution or any one country, but healthcare in general today is not personalized. It is focused on sickness, not wellness. It is hard to navigate. It is expensive. It is late stage and painful. Could you imagine, with the right application of the right tools, that it is proactive, it is wellness focused, it is easy to navigate, it is less invasive and lower cost? And actually, I think we are seeing shining examples of algorithms that democratize knowledge and reduce the burden on patients and families and gives them the answers they need faster.
What is the question that the three of you, and maybe you haven't thought about this, but help me ask better questions? And the better question I want to ask is, when I am involved in a conversation, whether it's on air or not, related to healthcare and AI, what is the question I should ask to determine what that answer is? Is this the right kind of business using AI? And you, all three of you have kind of intimated in a longer structure, but if you can just give me the one question that you would first ask that particular entrepreneur, startup, business unit who is talking about, we are using AI to do this, or we're doing this and we're thinking about doing AI, what's that question you're going to ask to see if there's a there?
I go back to what is it solving for? And
What's
then
it solving?
is it how are you going to connect with everything else? Because we have way too many point solutions with AI in them, but they're not connected.
John?
So
See, I was going to say, what does it solve? But I will add, can you trust it? How was this developed? I had a commercial provider come to me and say, we used almost 100 patients to develop this algorithm. Ooh.
So, can you trust it?
Right?
I'm going to ask really, okay, AI is good at doing a certain set of things: scale, analyze, compute, help you find the unknown.
One question though, yes.
So my question is, what aspect of this technology are you really focused on using, and how is that directly related to the problem you're trying to solve? Because it is very big.
We were talking about caregiving a second ago, and I'm very much committed to that we focus on a caregiving moonshot, for instance. That's me personally looking at this 100 million people living through at this $2.5 trillion, most of it untransacted spaces, as the audience heard me mention earlier. For the three of you, with the very idea that this is a hopeful potential application of something to really change things in big ways, AI and healthcare, what moonshot, I guess I might ask, do the three of you have based on being experts in AI? Because it's really opened up the aperture, hasn't it? For all, but you see so many opportunities. What is your big moonshot that you're looking at in the healthcare industry? Dipanita, you start this time.
To me, it's really bridging the gap between a physician who knows and a patient who is served. It's accessibility of science. It is not accessible today. You might reach it, but you won't understand it. And one of the things AI can do, if tuned and deployed well, is make information more accessible, more comprehensible. And when it comes to healthcare, and I am a caregiver at this moment in time, our ability to understand that information, to advocate for ourselves, and to have that conversation with our care team and our physician is essential. And I think AI can go a long way in that kind of accessibility.
Moonshot in healthcare.
So let me give you a moonshot. So when I was hired at Mayo Clinic, I was told I have a KPI of touching 4 billion people by 2030. And how does one touch 4 billion people? You have to curate the world's data. And so we've been talking about bringing country scale together, building policies that ensure what we do is safe and trustworthy, and get it used. 4 billion people to start.
I like 2 great moonshots so far.
For me, it's all prevention. So taking data that we're just not leveraging today in a nice way, and empowering all of us as consumers to stay healthy, to know what our body is, how it reacts to different things. And we can be stewards of our own health. Let's not wait till we get sick. So to me, putting this data and AI to use towards prevention, I think of it as precision health. right? So we're in the precision medicine, so post-diagnosis, whether it's diabetes or cancer, let's do precision health, and let's not limit it to the developed countries. Let's think of the globe, because all these chronic illnesses are rampant everywhere. Prevention takes the same approach, so and technology is everywhere. So,
Milken, please thank Divya, John, and Tapanita.
Thank you.